You might be dismissing the smallest signs of something serious, little whispers your body is sending that could mean rheumatoid arthritis is quietly starting to damage joints. Don't overlook these 12 warning signs of rheumatoid arthritis in seniors. By the time many older adults get a formal diagnosis, subtle damage may already be underway. If you're a senior or you care for one, recognizing these early signs can make a real difference in preserving independence and preventing irreversible loss of function. In the next 20 minutes, I'll walk you through 12 often missed clues, how they feel, why they matter, what to watch for specifically in seniors, and the practical next steps you can raise with a clinician. I'll also flag the 3 findings that tend to change the game for doctors because they can show disease before visible swelling appears. If this information matters to you or someone you care for, save this video and share it with a family member after watching. Rheumatoid arthritis isn't just worn-out joints. It's an immune-driven process that can simmer for months or even years before obvious swelling shows up. That slow, smoldering inflammation can affect energy, appetite, blood tests, imaging, eyes, lungs, and nerves, not only the hands and wrists. For seniors, early signs are often written off as normal aging, fatigue, or arthritis from wear and tear. That dismissal is exactly what allows irreversible joint damage and disability to accumulate. Think of RA like a whisper that becomes a shout. The early whispers are subtle, a stiffness that lingers after sleep, a tiredness that rest won't fix, small joint soreness that comes and goes. The sooner those whispers are heard and investigated, the better the chance that treatment can quiet the immune system and protect joints. Studies suggest earlier treatment with disease-modifying therapy is linked to better long-term outcomes, not a guaranteed cure, but a much better shot at preserving function. Below, each sign is presented in 4 short points: what it feels like, why it could reflect autoimmune inflammation, senior-specific clues to look for, and what you can do about it. 1. Deep, persistent fatigue and malaise that doesn't improve with rest. It's more than a lazy day or poor sleep. Many older adults describe a bone-deep tiredness that leaves them unable to finish tasks they once managed easily, folding laundry halfway, leaving dishes in the sink, canceling a short walk because it feels overwhelming. Fatigue in RA happens because the immune system is active all the time. Inflammation burns energy and changes how muscles and the brain respond to exertion. For seniors, this fatigue can be mistaken for depression, medication side effects, or simply getting older. Watch for a new pattern: energy levels that dip for weeks to months, loss of stamina on routine chores, or needing more naps than usual. If this kind of exhaustion is new or disproportionate to activity level, note how long it's been happening and mention it to the primary care clinician. Simple questions your clinician may ask include whether it's worse in the morning, how it affects daily tasks, and whether it fluctuates from day to day. 2. Recurrent low-grade fevers and flu-like feelings that come and go. These aren't the high fevers of infections. They're mild, around 99 to 100 degrees Fahrenheit, or simply a sense of being feverish. Seniors might shrug this off as a bug or seasonal malaise. Biologically, systemic inflammation can make the body run slightly hot and trigger general aches. What to watch for? Report of feeling feverish without a clear cause, repeated short episodes that resolve and recur, or an overall pattern of flu-like days without classic cold symptoms. If you or a loved one has recurring low-grade fevers, keep a simple log: gaits, temperatures if available, and accompanying symptoms. That log can help a clinician decide whether to investigate inflammatory causes versus infections or medication reactions. 3. Unexplained weight loss or decreased appetite. Losing a few pounds can be normal, but significant or progressive weight loss without trying may indicate chronic inflammation. In RA, inflammatory signals can alter metabolism and appetite over time. For seniors, weight loss is especially important because muscle mass and reserve matter for recovery and independence. Watch for clothes fitting looser, less interest in meals, or dropping weight over several months. Also note whether the weight loss is accompanied by fatigue or low-grade fevers. Bring any progressive, unexplained weight change to the clinician's attention. This could be a clue prompting blood tests and further evaluation. 4. Prolonged morning stiffness lasting more than 30 minutes that improves with movement. This is one of the classic early signs. Instead of the quick, "I'm stiff until I walk it off" story of ordinary arthritic stiffness, inflammatory stiffness tends to be longer and symmetric, both hands, both wrists, or both knees. Seniors often say their hands feel like gel after sitting, or they need time and movement before they can button a shirt or open a jar. Pathophysiologically, inflammation thickens the joint lining and fluid, producing that glued feeling that softens with activity. Look for stiffness that lasts half an hour or more after waking, or stiffness that recurs after periods of rest during the day. If it's interfering with dressing, hygiene, or meal prep, that detail is worth recording for your health visit. 5. Intermittent, mild joint pain or tenderness in small joints, especially symmetric involvement of fingers, wrists, or toes without obvious swelling. Early RA doesn't always present with dramatic red, swollen joints. Instead, it can start as intermittent tenderness or dull aches that come and go, often on both sides of the body. Seniors may complain about difficulty fastening buttons, trouble with zippers, or a steady ache when gripping a mug. The symmetry, the same joints on both hands feeling similar, is a key clue that distinguishes inflammatory disease from localized injury or osteoarthritis that is often asymmetric. Pay attention to patterns. Are the same joints involved on both sides? Does the pain wake you at night or linger after activity? Make a note of the specific joints and whether the discomfort is constant or fluctuates. 6. Burning or warmth sensations in joints. Sometimes you won't see clear swelling, but the skin over a joint may feel warm, or the joint may have a burning quality rather than a dull ache. That warmth reflects increased blood flow and localized inflammation. For seniors, subtle warmth without redness can pass unnoticed if fingers are cool from age-related circulation changes. Ask a caregiver to feel the joint compared to the opposite side. Warmth that is new or localized deserves mention. If a joint feels hotter than surrounding areas, or you sense burning while using that joint, tell the clinician. It may prompt targeted physical exam maneuvers or an ultrasound to look for synovitis. 7. Subclinical inflammation on imaging. Synovitis or bone marrow changes seen on ultrasound or MRI before clinical arthritis is obvious. This is one of the crucial game-changer clues. Modern imaging can pick up inflammation of the joint lining, synovitis, or tiny areas of bone stress, bone marrow edema, that precede visible swelling. For seniors who have unexplained symptoms, fatigue, stiffness, intermittent pain, an ultrasound or MRI ordered by a clinician can reveal ongoing inflammation that isn't obvious on basic exam. Why it matters? Imaging evidence of inflammation increases the likelihood that something more than wear and tear is happening and can justify early referral to a rheumatologist. For practical senior-focused cues, if physical exam is equivocal but symptoms are persistent or symmetric, ask whether ultrasound evaluation is appropriate. It can be quick, non-invasive, and reveal inflammation missed by the naked eye. At this point, you might be thinking, those first 7 signs could be subtle and easy to miss. That's exactly why paying attention now matters. Number 7, imaging evidence can reveal the disease process before you ever see dramatic swelling. But there are blood clues and immune tests that often show up even earlier, and some systemic features that point to RA beyond the joints. Keep listening. The next set of signs starts to shift the conversation from maybe arthritis to time to investigate further. 8. Mildly elevated inflammatory markers, CRP and ESR, on routine blood tests without an obvious infection. These are simple blood tests your clinician can order. They aren't specific to RA, but they do flag active inflammation somewhere in the body. For seniors, baseline levels may already be affected by other conditions, so small rises can be harder to interpret. What to watch for is a pattern. Repeat tests showing persistent elevation in the absence of infection or another clear cause. If your primary care clinician notices a consistent elevation in ESR or CRP alongside fatigue, prolonged morning stiffness, or symmetric small joint complaints, it raises the index of suspicion for inflammatory arthritis. Remember, normal tests don't entirely rule out disease, and mildly abnormal tests don't confirm it alone. They are pieces of a larger puzzle. As you think through these 8 signs, write them down if any apply to you or the person you care for. Note when they started, how often they occur, and which activities are affected. These concrete details build a clear picture for a clinician and help avoid the common trap of attributing everything to just getting older. For seniors, context matters. Comorbidities, medications, and functional baseline all influence how symptoms present. A new pattern of morning stiffness or a steady decline in energy is meaningful even when other conditions exist. Let's pause for a moment and imagine a typical morning. An older adult wakes up, reaches to button a shirt, and finds their fingers stiff and slow. They sit for 20 minutes, then move their hands, and the stiffness improves. They're more tired than they used to be, needing extra rest in the afternoon. At the grocery store, they notice their grip is weaker, and they can't open the pantry as easily. The local clinician checks basic labs. CRP is slightly above normal. There's no dramatic swelling on exam. In isolation, each point might be shrugged off. Together, though, they form a pattern that should prompt conversation about inflammation and possibly further evaluation, imaging, or an autoimmune blood panel. One practical step for seniors and caregivers is simple documentation. A short daily note, what a person could or couldn't do, how long morning stiffness lasted, any low fevers, appetite changes, or worsening fatigue, creates a timeline. Clinicians rely on such reports to decide whether to pursue targeted tests like ESR or CRP, a rheumatoid factor or anti-CCP antibody test, or an ultrasound. That documentation also helps determine urgency. A single bad day is less informative than a steady, progressive shift over weeks to months. It's important to remember that many common things can mimic these signs. Medications can cause fatigue. Heart failure, thyroid disease, or depression can lead to weight loss or low energy. Peripheral neuropathy or carpal tunnel from age-related wear can cause numbness. The difference in rheumatoid arthritis is the pattern. Symmetry, systemic clues like low fevers or blood test abnormalities, and the way stiffness improves with movement. Because seniors often have multiple health issues, a primary care clinician's role is to sort through what's likely age-related and what may be inflammatory, and your observations are a vital part of that process. Before moving on to the last 4 signs, including the immune tests and extra-articular symptoms that commonly change the course of evaluation, take a moment to consider whether any of the 8 signs above fit the profile of you or someone you support. If multiple signs are present, jot them down with dates and examples. That list will make your visit more productive and ensure the clinician doesn't dismiss concerns as vague or not specific. Knowing when to ask for further testing is tricky. A single mild symptom usually doesn't warrant aggressive workup, but when 2 or more of the items we've covered appear together, for example, prolonged morning stiffness plus symmetric small joint tenderness and a slightly elevated CRP, it raises the chance that an inflammatory process is at play. That's when clinicians commonly consider autoimmune screening and targeted imaging to look for synovitis. These steps aren't about scaring you. They're about making an evidence-based decision. Is this a reversible, treatable inflammatory disease, or is it something else entirely? Caregivers play a key role here. Often a family member notices subtle declines before the older adult does. If you're watching a parent or spouse, you might observe changes over weeks that the person themselves thinks are normal. Bring those observations to the visit with specific examples. He's needed help buttoning his shirt for the past month. Or she hasn't been able to carry the laundry basket like she used to. Concrete, time-stamped examples help clinicians prioritize tests that could reveal early disease. One more practical note. When reporting symptoms, be specific about symmetry and timing. Symmetric complaints, both hands, both wrists, steer the clinician toward inflammatory causes. Describe stiffness in minutes. It lasts about 45 minutes after waking is more useful than "I'm stiff in the morning." Mention fluctuations. It comes and goes versus it is constantly painful. These small details change clinical judgment and can be the difference between watchful waiting and prompt referral. As we prepare to look at the remaining signs, keep in mind that the next cluster includes the immune markers and systemic manifestations that often move a clinician from suspicion to action. These features are more than descriptive. They influence the tests ordered, the urgency of referral to a rheumatologist, and sometimes the need for pulmonary evaluation or neurologic assessment. In older adults, early referral can preserve function and reduce the risk of complications, which is why recognizing these whispers now can have outsized benefit later. 9. Presence of autoantibodies, rheumatoid factor, and anti-CCP or anti-ACPA. These are the immune system's fingerprints.
Sometimes they appear years before joints start to hurt. In practical terms, a positive anti-CCP or RF test doesn't by itself prove you have active disease today, but it does raise the likelihood that an inflammatory arthritis could develop or already be smoldering beneath the surface. For seniors, there are a couple of important nuances. First, low-level positives can sometimes be seen with other conditions or with age-related immune changes, so results must be interpreted together with symptoms and other tests. Second, when a senior has the combination of symmetric small joint complaints, prolonged morning stiffness, and a positive antibody test, clinicians take notice. That pattern increases the chance that the symptoms are autoimmune rather than purely mechanical. If you or your loved one has had blood work showing RF or anti-CCP in the past, bring that result to the visit. If these tests haven't been done and multiple warning signs are present, ask your clinician whether autoimmune antibody testing is appropriate as part of the evaluation. 10. Subtle blood count changes, mild anemia or slight shifts in white cells or platelets. Chronic inflammation quietly affects how your body handles iron and how bone marrow functions. In rheumatoid arthritis, it's common to see a mild normocytic normochromic anemia, meaning hemoglobin that's lower than expected but without obvious iron deficiency features, or small, nonspecific changes in white cell counts. For an older adult, a slow decline in hemoglobin, a persistent low-grade anemia, or unexplained lab abnormalities that don't fit another diagnosis should prompt a broader look. Why does this matter? Because these blood changes are another piece of the inflammation puzzle. They don't prove RA, but when they appear alongside fatigue, low fevers, or elevated CRP-ESR, they push the clinician toward investigating an inflammatory cause. Practical senior cues include repeated lab reports showing downward drift in hemoglobin or a doctor noting mild anemia of chronic disease without a clear source. If that happens, ask whether inflammatory arthritis has been considered. 11. Extra-articular signs. Dryness of the eyes and mouth, subtle lung complaints, small nodules under the skin, or tiny changes in skin circulation. RA is a systemic condition. It doesn't stop at the joint line. Dry eyes or a persistently gritty feeling may reflect associated autoimmune activity, sometimes linked to conditions like dry eye syndromes. Persistent cough, unexplained breathlessness, or new dry-dependent shortness of breath can signal lung involvement. In older adults, lung disease has many causes, but when respiratory symptoms occur alongside joint and systemic signs, pulmonary evaluation becomes relevant. Rheumatoid nodules, firm bumps under the skin, often near pressure points, are less common early but are a clear extra-articular clue when present. 9. Subtle blood count changes, mild anemia or slight shifts in white cells or platelets. Chronic inflammation quietly affects how your body handles iron and how bone marrow functions. In rheumatoid arthritis, it's common to see a mild normocytic normochromic anemia, meaning hemoglobin that's lower than expected but without obvious iron deficiency features,
or small, nonspecific changes in white cell counts. For an older adult, a slow decline in hemoglobin, a persistent low-grade anemia, or unexplained lab abnormalities that don't fit another diagnosis should prompt a broader look. Why does this matter? Because these blood changes are another piece of the inflammation puzzle. They don't prove RA, but when they appear alongside fatigue, low fevers, or elevated CRP-ESR, they push the clinician toward investigating an inflammatory cause. Practical senior cues include repeated lab reports showing downward drift in hemoglobin, or a doctor noting mild anemia of chronic disease without a clear source. If that happens, ask whether inflammatory arthritis has been considered. Small vessel changes such as unusual skin spots or non-healing ulcers are rare but important signs of systemic inflammation. For seniors, these manifestations may be subtle: a new chronic dry cough, an increase in dry eye symptoms requiring more drops, or a small painless lump under the elbow that wasn't there before. Document these findings and report them. They change the urgency and direction of evaluation. 12. Peripheral nerve symptoms, numbness, tingling, or early carpal tunnel signs. Inflammation around joints and tendons can compress nearby nerves, and small fiber neuropathy can be an early extra-articular feature of autoimmune disease. For many older adults, hand numbness is often attributed to pinched nerves or diabetic neuropathy. The distinguishing features to watch for are bilateral involvement, both hands having similar symptoms, nighttime numbness that wakes you, or numbness that occurs together with morning stiffness and symmetric small joint complaints. Early carpal tunnel from inflammatory swelling often responds differently to typical repetitive strain explanations because it appears alongside other systemic clues. If someone describes persistent or worsening numbness, tingling, or weakness, especially if it's symmetric or accompanied by joint stiffness, mention it to the clinician. Nerve symptoms may lead to nerve conduction studies or an ultrasound to look for inflammatory swelling and can be part of the case for earlier referral. These last 4 signs complete the 12 warning signals you should not overlook. Pause for a moment and picture how they might cluster. Persistent fatigue, a few low-grade febrile days, morning stiffness that lasts half an hour or more, symmetric hand discomfort, a slightly elevated CRP on routine labs, and perhaps a positive anti-CCP from prior testing. Alone, any one of these could be attributed to something else. Together, they form a clearer image, a constellation that deserves investigation. Why numbers 7, 8, and 9 are game changers. Let's emphasize something clinicians often stress. Imaging, inflammatory markers, and autoantibodies are the high-impact clues. Number 7, imaging, number 8, CRP-ESR, and number 9, ACPA-RF, are frequently the findings that move a physician from watchful waiting to active evaluation and sometimes early treatment. Imaging, ultrasound and MRI can reveal synovitis, inflammation of the joint lining, or tiny bone marrow changes long before classic swelling is visible to the eye. This is especially helpful in older adults whose baseline joint changes from osteoarthritis or prior injuries can cloud the exam. An ultrasound is quick, non-invasive, and can be done at the bedside in many clinics. MRI is more sensitive for bone marrow edema and deeper joint changes. For a senior with persistent, symmetric symptoms but a subtle physical exam, imaging that demonstrates active inflammation is a strong signal that the process is inflammatory rather than purely mechanical. Inflammatory markers, CRP and ESR, are blunt tools, but they tell you whether the body is fighting something. Persistent elevation of these markers, especially when infections and other causes are excluded, raises the probability of inflammatory arthritis. In older adults, interpret these numbers in the context of other illnesses. Low-level chronic inflammation is common, but a consistent pattern of elevation alongside symptoms should prompt further testing. Autoantibodies. A positive anti-CCP ACPA is among the most specific blood clues physicians have.
When anti-CCP or a high rheumatoid factor is present with compatible symptoms or imaging findings, a clinical picture strongly favors rheumatoid arthritis. Importantly, these antibodies may be detectable years before joint symptoms flare, which gives a window of opportunity for monitoring and early intervention. When imaging, blood markers, and antibodies align, rheumatologists and primary care clinicians are more likely to consider disease-modifying strategies sooner rather than later. That timing matters because earlier initiation of appropriate therapy has been associated in multiple studies with better preservation of joint function and reduced long-term disability. Remember the caveats. Tests are not perfect, results must be interpreted in context, and treatment decisions are individualized. What to do next? A step-by-step checklist for your visit. If you've noticed one or more of these warning signs in yourself or a senior in your care, here's a practical, clinician-friendly checklist to prepare before the appointment and what to discuss during the visit. Bring this information to make the conversation efficient and focused. Before the appointment, document the pattern. Symptom diary. Record which signs are present, the date they started, how often they occur, and how long they last. Be specific, morning stiffness 45 minutes, or felt feverish 99.5 degrees F on 3 mornings this month. Functional examples. List activities that have become harder: buttoning shirts, opening jars, carrying groceries, preparing meals. Note when these changes began and whether they've progressed. Medications and health history. Bring an up-to-date list of all medications, including over-the-counter supplements, recent infections, vaccinations, and known autoimmune or lung conditions in the family. Objective data if available. Recent blood work results, CBC, basic metabolic panel, CRP and ESR, prior antibody tests, and any imaging reports. Photos or short videos. A quick photo of a hand at rest or a short video showing difficulty with a task can be remarkably helpful. During the visit, key topics to raise. Describe patterns, not just single episodes.
Use symmetry and timing language. Both hands are stiff in the morning for about 40 to 60 minutes, or she's more tired than usual for several months. Ask if the clinician thinks inflammatory causes should be considered and which tests they recommend. Suggest specific tests to discuss, phrased as questions, not orders. CRP and ESR to check for inflammation, a rheumatoid factor and anti-CCP test for autoimmune markers, and a CBC to look for anemia or subtle blood changes. If the exam is equivocal but symptoms are persistent and symmetric, ask whether an ultrasound or MRI would be appropriate to look for early synovitis or bone marrow changes. Bring up extra-articular symptoms, dry eyes, persistent cough, nodules, or new numbness. These broaden the evaluation and may prompt pulmonary or neurologic testing. Ask about referral. If multiple indicators of inflammation are present or if symptoms are progressive despite conservative measures, discuss referral to a rheumatologist. Rheumatology referral is often the next step for diagnostic clarity and to discuss possible disease-modifying therapy. Tests explained in plain terms. CRP and ESR measures that detect inflammation in the body. They don't say what's causing the inflammation, but they help show whether something systemic is happening. Rheumatoid factor and anti-CCP blood tests that look for antibodies commonly associated with rheumatoid arthritis. Anti-CCP is more specific. Positive results raise suspicion for autoimmune arthritis, especially when combined with symptoms or imaging. CBC, complete blood count, looks at hemoglobin and cell counts. Mild anemia or stable downward trends can be another clue suggesting chronic inflammation. Ultrasound, a real-time scan that can reveal inflamed lining and increased blood flow in joints, quick and non-invasive. MRI, a detailed scan that can show bone marrow edema and early joint changes not seen on X-rays, more sensitive but less available and more costly. Pulmonary imaging. Chest X-ray or CT may be considered if respiratory symptoms are present, because RA can involve the lungs in some patients. What early treatment means without prescriptions. If your clinician and rheumatologist conclude that an inflammatory arthritis is likely, they may discuss disease-modifying approaches. The important point to understand is this: earlier treatment aimed at controlling the immune process can limit joint damage over time and better preserve function. That does not mean every person with one positive test needs medication. Treatment decisions depend on symptom severity, objective evidence of inflammation, patient health, and goals of care. Always follow shared decision-making with your healthcare team, asking questions about benefits, risks, monitoring plans, and how treatment would fit with other medical conditions. Practical tips for seniors and caregivers during the diagnostic phase. Be persistent but patient. Because seniors often have overlapping conditions, it can take time to sort out the cause of symptoms. Keep returning to the pattern you've documented. Coordinate care. Ensure the primary care clinician and any specialists, pulmonology, neurology, cardiology, have the same timeline and list of symptoms. Shared records and clear notes reduce repeated testing and speed diagnosis. Medications review. Polypharmacy is common in older adults. Ask the clinician to review current medications for side effects that might cause fatigue or weight changes. Maintain baseline function. Gentle, joint-friendly activity, as tolerated and cleared by the clinician, helps preserve strength and mobility while the diagnostic process continues. Physical therapy referral can be useful even before a definitive diagnosis to maintain independence and reduce fall risk. Home safety. If hand strength, balance, or sensation is declining, consider simple home modifications, jar openers, button hooks, grab bars, to reduce frustration and maintain safety. Emotional support. Facing a potential chronic illness is stressful. Reach out to family members, support groups, or your clinician's social worker to connect to resources. When to seek faster evaluation. There are situations that warrant more rapid assessment. Rapidly worsening function. For example, suddenly unable to use hands for essential tasks. New or progressive breathing difficulty, unexplained, especially when accompanied by joint symptoms. New neurologic deficits, sudden persistent numbness or weakness. Markedly raised inflammatory markers without an obvious cause. If any of these occur, ask for expedited testing and consider urgent specialist input. A short, realistic case to illustrate the path. Imagine Mildred, age 72. Over 6 months, she's grown increasingly tired, losing a bit of weight, and needing naps after lunch. She notices both hands stiff each morning for about 45 minutes, and she can't button her cardigan without help. Her primary care visit shows a slightly elevated CRP and a mild anemia. Her clinician orders an anti-CCP test and an ultrasound of the hands. Anti-CCP is positive, and ultrasound shows mild synovitis in the wrist. Because the pattern is symmetric, systemic, and supported by blood and imaging, she's referred to rheumatology. Early discussion leads to a personalized plan aimed at controlling inflammation and preserving hand function. That path, observation, targeted testing, early referral, illustrates how the whispers can be acted on before larger problems take hold. Reassurance about treatment advances, measured, not miraculous. It's important to close this section with a balanced message. Treatments for inflammatory arthritis have improved substantially over recent decades. Modern strategies focus on controlling inflammation early to prevent joint destruction and preserve quality of life. For many people, symptoms can be managed effectively and independence maintained. That said, outcomes vary by individual, depend on timely diagnosis, overall health, and close follow-up, and no clinician can promise a guaranteed cure. The aim of early recognition is to maximize the chance of a positive, function-preserving outcome. Final practical checklist to bring to your clinician. Say it out loud or write it down. Which of the 12 signs are present? List them and dates of onset. How long does morning stiffness last, in minutes? Are symptoms symmetric? Both hands, both wrists, both knees? Any low-grade fevers? Note temperatures and dates if possible. Any unexplained weight loss? How much and over what time? Any numbness, tingling, or weakness? Describe sides and timing. Any new dry eyes, persistent cough, or skin lumps? Recent blood work or imaging results? Bring copies or ask for electronic transfer. Current medications and major past medical history. A short video or photo showing functional difficulty, optional but helpful. Caregiver-specific suggestions. Keep a simple log with dates and short notes. Clinicians value concrete timelines. Bring the patient to appointments when possible. Sometimes they underplay symptoms in the moment. Help the clinician by pointing out specific, repeatable examples. He has needed help with buttons every morning for the last 3 weeks. If the senior has memory issues, bring medication lists and prior medical records to avoid confusion. Parting reassurance and a clear action step. The point to take away is simple. Don't accept a slow decline as inevitable without a conversation. Some changes are part of aging, yes, but a cluster of the signs we described, especially symmetry, prolonged morning stiffness, persistent fatigue, mild fevers, and abnormalities on blood work or imaging, are reasons to ask your clinician about inflammatory arthritis. Early identification opens options that preserve independence and quality of life. If you or a senior you care for has multiple of these warning signs, make an appointment with your primary care clinician and bring your symptom notes, any prior lab or imaging results, and examples of daily tasks that have become harder. Ask whether CRP, ESR, ACPA-RF, CBC, and targeted imaging, ultrasound or MRI, might help clarify the picture. And discuss whether a rheumatology referral would be appropriate. Persistence is appropriate here. Clinicians rely on the pattern you describe. Thank you for taking the time to learn these 12 warning signs. Remember, these are whispers that can be heard and acted upon. The sooner the pattern is recognized, the more options are available to protect mobility and independence. If multiple signs apply to you or your loved one, schedule that conversation with your clinician and bring this checklist with you. Your observations matter. They often make the difference between delayed care and early, effective action.